Okay, let's spend some time talking about abdominal and pelvic imaging procedures in CT. So in general, CT abdomen and pelvis is going to require the most prep of pretty much anything that we do, and that largely relates to the oral contrast required for these procedures. So it's important for us to think about how oral contrast works and how best to prepare the patient for adequate imaging. Now, occasionally we have to use rectal administration. Typically, that's not too often. Some places it's part of an ER protocol just to increase patient throughput, or at times with colon cancer staging. And then the bladder, a lot of institutions will require us to do like a bladder delay, like a 5-minute delay after intravenous contrast administration, just to better visualize the bladder. In the case of when we're doing like a renal stone protocol, it's best to scan the patient with a full bladder or ask them not to void prior to scanning. So the IV contrast is going to help us better visualize the blood vessels and increase the density of vascular organs like the spleen or the liver or the kidneys. And it will also help us to differentiate between lesions and normal structures. I think about particularly like things like hemangiomas or tumors. It's really important for us to know appropriate timing and dose rates for IV contrast administration. And for the most part, we want to make sure that we're getting images before the contrast reaches an equilibrium phase. So typically we're talking about an arterial phase of contrast if we're evaluating the abdominal aorta and any arterial structures within the abdomen, or like a runoff study. Occasionally we'll want to do like a 3-phase liver study. That would be the liver non-contrast, then the liver in an arterial phase, and then a liver in the portal venous phase. And then other structures that might require multiphasic imaging might include the pancreas. Multiphase imaging of the pancreas will also typically give the patient water to drink prior to scanning. Even though we may ask for barium within the small bowel or the large bowel, we may give them a little bit of water right before we scan, like 30 minutes prior to scanning, and that will help better appreciate if there's any stones. With any given slice of abdominal CT, there's more information that can be displayed in a single window width and level setting. So typically images are often reviewed in 2 or more window settings. A lot of times we send the images to the physician with 2 separate preset window levels, like a soft tissue and something that shows kind of bony anatomy a little bit more clearly. The display field of view should be just large enough to include the skin margin. This is especially critical if we're doing CT scanning for any kind of cancer patients or for radiation therapy planning. I think it's also helpful with PET CT scanning, because that skin margin for PET CT fusion images, the skin margin is a helpful guide as to whether or not the images are properly fused. From an oncological point of view, if we know that we have skin margin, we can evaluate for any lymph nodes or metastases. And occasional from a diagnostic point of view, if we have certain kinds of hernias, they might get clipped if we clip part of the skin margin. So just as a rule, it's best to make sure that we include skin surface over the area being imaged. Now, in the case that previous studies are available, it's generally advisable to use the same display field of view, unless like a change in the patient condition necessitates. So, although landmarks are used to set up a range of cross-sectional slices, technologists must verify that the anatomy of interest is indeed being scanned. I think in particular about with the GE scanner, you have a little guide that you can flip around whether you got the patient position with their head towards the gantry or feet towards the gantry. And if the technologist overlooks or changes patient position but forgets to indicate that in the scanning protocol, that can definitely cause some problems. Also, just being aware of where you're zeroing to. It may be helpful to zero to like the xiphoid process and then begin the scan like 10 centimeters above that or something like that. You just want to make sure that you include everything from the diaphragm, generally through the pubic symphysis. And then scanning, if at all possible, scanning should not start or stop in the middle of obvious abnormality. I think in particular about CTA of the abdominal aorta, you want to make sure that if, for instance, a dissection continues into the common iliac, that you track with that you don't stop scanning in the middle of that. If, for example, you you notice an abnormality on the liver, but due to patient breathing, a portion of the abnormality was clipped or missed somehow, scan through the entire organ again. Just to allow for proper measurements both in the X and Y plane as well as in the Z axis. So most protocols are going to be asked for the patient to be positioned supine with their arms up, and that just gets the arms up out of the area of the abdomen to prevent any beam hardening. And in general, patients are asked to suspend respiration. So a lot of times it'll help a little bit if we ask them to take a deep breath in and hold it. And this will just reduce movement and decrease motion artifact, as well as kind of compact the area that we're scanning to maybe save them a little bit of dose. So, in general, the liver is going to have Hounsfield units between 30 and 70. And in a healthy subject, the liver is at least 10 Hounsfield units greater than the spleen. If we suspect fatty infiltrates within the liver, that's going to make the liver almost equal to the spleen will be almost equal to the liver. Another common finding in the liver is cavernous hemangiomas. They'll show up as kind of areas of decreased density within the liver, kind of irregularly shaped. Okay, so for a routine abdomen CT, there's going to be a little bit of the chest that we see within it. We may need to do a separate set of pictures just for the lung windows, just for the area of the lung. And often the liver is scanned just once on the initial injection of contrast, so typically in a portal venous phase. And with some indications, we may want to scan more than once for like kind of multiphasic enhancement. So there's certain hyper-enhancing tumors that may be better visualized with like an arterial and a venous phase of imaging. So just quick review. Hopefully you've read your chapter in your book, but question. A measurement for an ROI measurement of a CT image of the abdomen is showing a liver density at 35 Hounsfield units, whereas the density of the spleen is closer to 65 Hounsfield units. What is the likely diagnosis? Now, this difference in their Hounsfield units is because they're both very vascular organs, and so we're talking about them collecting contrast, but the liver has clearly collected less than the spleen. So what we're talking about in this case is C, fatty infiltrate of the liver. And looking at page 302 in our book, kind of middle of the page, it says, many operators include a region of interest measurement of the liver and of the spleen. A spleen measurement that is more than 10 Hounsfield units higher than that of the liver indicates fatty infiltrate of the liver. So, the pancreas is typically located between T12 and L2, but it can differ from patient to patient and significantly, both in size, location, and orientation. And as I mentioned before, water or like a low attenuation oil contrast may be preferred to something like barium. because it may obscure, the barium may obscure like small stones. Sometimes we may give barium initially, and then, and this is often the case, the patient shows up at the department for a CT of their abdomen, they are scheduled for a CT of the abdomen, but then we look at the doctor's orders, it says CT of the pancreas. So if that's the case, it's fine. If they've had some barium to drink, we'll just give them a big cup of water right before we do the scan. That way their stomach and some of the duodenum will be filled with water rather than barium. And we'll do a multiphasic IV contrast so we'll do an initial scan without just of the pancreas, then an arterial pancreas, and then a venous phase of the entire abdomen. That's a institution dependent, but that's one possible protocol. When the initial scans fail to differentiate the margins of the pancreas from the duodenum, the patient may be given even more negative contrast, and more kind of thinner cuts might be obtained. Or we may reposition the patient in a right decubitus position. Okay, almost all examinations of the kidneys are going to be using IV contrast, except for the case when we're looking for a renal stone, kidney stone. And then enhancement phases of the urinary tract include a corticomedullary phase, and this is about 30 to 70 seconds after the contrast media bolus. Then nephrogram phase, so we're going to see the kidneys just really lighten up like light bulbs at about 100 to 120 seconds after the contrast media injection, and then we'll see an excretatory phase, so we'll see more contrast in the renal pelvis and the ureters and the bladders at about 3 minutes after contrast media injection. CT urography, this is kind of new stuff, but the idea is to be able to look at the kidneys and the ureters and bladder in an excretatory phase. And there's a bunch of different protocols. The book mentions like biphasic kind of protocols where we do an initial injection, wait 2 minutes, do another injection, and then scan. So the idea is then to be able to see the kidneys in a corticomedullary as well as in a excretatory phase. But yeah, not super common. CT of the adrenal glands. CT is kind of a modality of choice for evaluation of the adrenal glands, as the book mentions on page 305. Determining whether an adrenal mass is benign or malignant is accomplished by assessing its attenuation values and by evaluating the degree of contrast media that is washed out of the mass on delayed imaging. So it's really, really important for us to be able to pick out the adrenal glands. Expect to see a question about adrenal glands on the quiz, because a good technologist is going to be able to save the patient a lot of time and money and radiation exposure, as well as going to save the radiologist time if we can just know to do a repeat examination for what they call like an incidentaloma, right? The book mentions that researchers have coined the term incidentaloma to describe kind of adrenal masses of and again, like the way that we're going to be able to determine whether or not this adrenal mass, what the characteristics of the adrenal mass are, is going to be by assessing their attenuation value and by evaluating the degree of iodinated contrast that is washed out of the mass on delayed imaging. So most CT abdominal pelvis protocols with IV contrast call for delayed imaging through the kidneys, ureters, and bladder. What we're talking about is on that delayed imaging, just scanning a little bit higher to include all of both adrenal glands in the case that there is an incidentaloma. So there are some specialized adrenal imaging protocols, and they're going to attempt to further characterize adrenal gland. And the goal of imaging is to reduce the number of unnecessary biopsies, the number of follow-up studies needed for accurate diagnosis, and just basically cost efficacy of care. So, the two unique features of adenomas on CT are used to differentiate from benign malignant lesions. So there's intracellular lipid, fat content, and then contrast media washout. And again, washout can only be evaluated on delay images. So here's a really common reason for a CT of the abdomen and pelvis: right lower quadrant pain. So the doc wants to evaluate the appendix. These patients come to us as outpatients or ER patients, or at times from the floor. The variable position of the appendix is important because it's very difficult to, there's a diverse kind of clinical presentation of acute appendicitis. I personally have a very difficult time picking it out, just even locating the appendix. I'm proficient with locating it about 6 out of 10 times. And that's because of this variation in positioning, and it makes the appendix more challenging to locate on just axial images. So a lot of times post protocol, we may be doing coronals. Most CT abdomen pelvis for appendicitis are going to call for coronal reconstructions. At times the doctors may even ask us for sagittal reconstructions, and it just goes back to kind of that diverse clinical presentation. Appendicitis protocols are going to vary widely, as I indicated before. At times they may call for rectal contrast, depending on the institution, or they may ask for no contrast media or contrast media at all. And a final consideration with these varying protocols is in their rate of providing an alternative diagnosis when the appendix is found to be normal. So negative for appendicitis, but is there a kidney stone, or is there diverticulitis, or etc. So a CT renal stone protocol. The terms renal stones, kidney stones, renal calculi, nephrolithiasis, urolithiasis are often used interchangeably. Stones. There are 4 basic types of urinary stones, and it can be seen on non-contrasted, so we don't have to give them any contrast at all. No oral, no IV contrast. These are like the bread and butter exams. So just non-contrast helical scan of the abdomen and pelvis. And more than 99% of stones, including those that are seen on radiolucent or plain film X-ray, will be seen on non-contrast helical CT scanning. So these are the guys who come in 3 o'clock in the morning on Sunday night, and they feel like they've been stabbed in the back with a knife, and something was apparent on X-ray, or maybe they just referred them directly to CT for renal stone protocol because there was a hematuria. So protocols use a helical scan mode from the top of the kidneys through the base of the bladder, and typically want a thinner slice thickness, so 3 millimeters or less. 2.5 millimeters by 2.5 millimeters is a pretty common stone protocol. The biggest drawback for this is the relatively high radiation dose, particularly to the gonads. And this is of concern because people who form renal calculi are typically young and have a tendency to have repeated stone formations. So even though this is kind of a bread and butter exam, honestly it would be great if we could evaluate it initially via X-ray and skip the CT altogether. So the protocols that we should review in our book and be most familiar with are routine abdomen pelvis protocol, so oral and IV contrast, an abdomen pelvis aorta, so this would be post-stent. It's not a gated protocol like the CTAs of the heart, but we would trigger off of the ascending aorta or perhaps the descending aorta and scan through the aorta, through the bifurcation, perhaps down to the level of the femoral arteries, just depending on indications. As we mentioned before, there may be like a triphase liver, so a non-contrast liver followed by arterial phase and then venous phase of the entire abdomen and pelvis. Also a triphase pancreas, so non-contrast through the pancreas, then an arterial phase pancreas, and then a venous phase of the entire abdomen and pelvis. Mesenteric, so reviewing those mesenteric arteries, we're able to do that a lot more clearly now, and we can do post-processing for MIPS of those as well as 3D rendering of them, and then enterography. A few more. As we mentioned before, appendicitis or diverticulitis protocols. These are going to be oral and IV contrast scanned through the abdomen and pelvis with about a 60-second delay. Follow it up with a delay scan of the kidneys, ureters, and bladders in case it's negative for appendicitis. They can evaluate for other things like a abscess. Colonography, which we're not going to get into a lot of detail on, but basically these patients are a lot of times scanned both supine and prone, and we may be using rectal contrast. In particular, we might be using air or room or CO2 to create like a fly-through on post-processing. Adrenal mass, so this is one of those, like we mentioned earlier, the incidentalloma, where something is apparent in the one of the adrenals or both perhaps in an initial like venous phase of contrast, and so it's just a matter of making sure that we do that delay scan to include both adrenals so that we can evaluate for washout. Renal mass, so we can do triphase of the kidney itself, so evaluating the kidney at corticomedullary as well as excretory phase. Renal stone protocol, this is the beautiful scan where we just do a helical scan at like 2.5 millimeters without any IV or oral contrast, and then a CT urogram. All right, that's it. Thank you so much.